I wish to acknowledge the traditional custodians of the land we are meeting on, the Whadjuk Noongar people. I wish to acknowledge and respect their continuing culture and contribution they make to the life in this city and this region. Next month we've got Mark Pastovicius talking on boron-based solid-state electrolytes for next generation of batteries, and in May we've got Colin Wheatley. I'd like to thank Dr. Johan Janssen for coming to give us a talk today. It's how to avoid a pig's heart transplant. Dr. Johan Janssen was trained as a cardiologist in Maastricht, the Netherlands, under Professor Hein Wellens. After his PhD in cardiac imaging, he joined the faculty as an associate professor before he moved to Rotterdam as an interventional cardiologist. He was subsequently asked to head a new cardiac development program in the Kingdom of Saudi Arabia. After an exciting time in the Middle East, Dr. Janssen and his family moved to Perth, where he joined Western cardiology. His interests are preventative medicine, diagnosis and treatment of cardiac arrhythmia, diagnosis and treatment of coronary artery disease, aspects of alternative medicine, and sports medicine and the heart in general. In addition, in 2016, he was awarded the Prize for Extraordinary Service to rural Western Australia. And Dr. Johan Janssen has been listening to, measuring and mending his patients' hearts for over 40 years. As such, he has numerous scientific publications and chapters in cardiology books. And he's also written a book, Your Heart Maintenance.
Thank you very much for having me here. I am retired since 7 months now, 8 months. And I'm lured here because Ferdy knew me and he thought that he could benefit maybe from my insights in the world of the heart. And because we have read about the pig's heart transplant, which has been attempted a couple of times, but now it has been successful, I thought it might be a good idea to talk about how we can prevent that, to have a pig's heart transplant. I have to go back to, let's say, the 1400s, when we had the plague. And in the 8 years of the plague, they estimated that 60% of the world population died. Then we had the First World War, atrocious, 55 million died, but we're not so sure who died actually from the war or who died from the concomitant viral illness, the flu, which was rampant in those years. Then we had the Second World War, and we managed to kill off 3% of the population, like 55 million. And it's interesting that more civilians died than soldiers. So maybe it's an idea to just get rid of the soldiers so we all stay alive. Would be maybe a thought. And then we have COVID. Now, look at COVID. 2 years of COVID. 6 million people plus died. But in WA, only 13. Now, how do we deal with that as persons? Now, here in WA, most people have been very comfortable. We have been able to do our things, minus a couple of days or weeks of lockdowns. But we have been able to go about our business, do our shopping, go to the uni, do some work, do even more work. I wrote a book during COVID. But now we are getting more COVID because we're open. Suddenly, we have COVID with restrictions, trains that don't bring stuff, so our supermarkets are empty. We have this war going in with this lunatic Putin, with the biological warfare, maybe worse, who knows. And suddenly, we feel that it is encroaching on us, and we're getting worried about things. And I think, in my experience, that is exactly how we look at our health. We are invincible. Invincible. When we're young, we daredevils. By the way, we are daredevils because we have certain hormones that will dissipate when you're between 25 and 30. And that is when people say, oh, they calm down because they've got a family. And no, it isn't because of that. It is because we are lacking that hormone. That's why young guys are doing UWIs and things like that. And that's why young guys are going to war and being stupid. When you then get older and you get families or you get a career, nothing much happens. You stop doing any sport, you're getting a belly, you drink too much, you get inactive, and some of you will get a love for playing games in front of a big telly on the floor with the chips and a bag of beer. Great stuff. And that's maybe good for the mental exercise, but maybe not good for our general health. And then suddenly, oh, something happened. And now what has happened is two cricketers, I'm not a cricketer, I find it a funny game to not have a winner after 7 days, but 5 days. See, that's how much I know. But we have two guys that died from a cardiac cause. One after a large heart attack of heart failure, and one because probably reading between the lines of the news, because what we call a widowmaker. Now, if I was working, I would have a 150% increase in new young guys coming to get a checkup. Because suddenly they are confronted with mortality. Oh, 51 he was, you know. And the same thing happens when people have somebody they know that dies or had a big problem, and they get suddenly worried and they look to themselves and say, oh yeah, I'm a little bit fat, I'm smoking, and maybe I should do something. So what I want to do today is I want to take you in a very schematic way through the heart and what you can do yourself. And you have to do that. You have to manage your own heart and your own problem and find out whether you do have a problem or a potential problem. Ferdy just told me the department I was working is not the same anymore now you're not there. I said, how come? Oh, he might be good, but he doesn't do a stress test, and he doesn't do the blood test, and he doesn't do this, and he doesn't do that. He just asked me 10 questions. Are you sure the bread? Do you have this? Do you have that? Are you still married? Yes, okay, good. See you next year. Right? And that is a problem. Because if you're not in the mindset of preventing stuff, then it will never happen. If you just wait till the problem or the shit hits the fan, and I'll come back to this shit later, because young shit might be good for you, then you are really running behind the facts. Now we know already for more than 20 years that there are a lot of things that you can do long before people get a heart problem. So once we go into the talk, we'll see that. Now, you're all chemists, isn't it? So we'll talk about this a little bit later, huh? When the pizza comes. I know that you know what that is. Huh? I had to look it up. You know what that is. Huh? Yes. There you go. That is. Now, we have a heart. That looks like a heart. And the heart has three main components. It has a muscle with some valves. Because the heart is nothing more than a pump. Right? It is a very good pump, a very complicated pump, but it's nothing more than a pump. It pumps blood. Second thing is we have arteries. And those are little tubes that bring blood to the heart and from the heart. And the arteries from the heart itself are called coronary arteries. And then the third and last one is we have an electricity system to get the heart moving, so it beats. Now, the heart is an incredible organ because if you take this bottle and you move it up and down, depending on your fitness level, you can do 10 times, maybe 100 times, but there will be a time that your muscle gets fatigued, you produce too much acid, and you have to stop. Your heart doesn't do that, eh? Before you were born, it was already going, and it stops when you die, and that's it. It never tires. And that is the reason why last century, when we thought about wrapping failing hearts with the muscle from the back, why that failed? Because we cannot train ordinary muscles to be able to work like the heart. So it's a unique muscle that doesn't tire. Now the muscle can have problems, and that is related to, there can be an infection of the heart muscle. And if the heart muscle gets infected, it can not contract that well. It can become thin, and then it can become too big. It can die off, like with a heart attack or with a virus infection. Or it can be very much inflamed and therefore collect that much fluid that it stops working. And that is what happened to young people that died with COVID. They get an inflammation of the heart muscle, and then instead of pumping, it stops pumping. And they get an arrhythmia because of that, and you find them dead the next morning. Right? So the muscle can have different problems. The valves in between the heart, and I'll draw some. So if this is the heart, then the heart is divided in 4 compartments. The blood comes from the body into the right atrium. Atrium because the Romans, they call the entry, the lobby of the house, the atrium, and the heart receives the blood here, so when somebody named it, we called it the atrium. And it's the right atrium, out of interest, because they used to look at people when they were dead, and then on their back. And then you open them up and look at it. And then the heart looks like this, flat, and you have a right and a left side. But when you're alive, then it's this front and the back, because the heart is rotated. So the right side of the heart is in the front, and the left is in the back. So if you want to kill somebody, you have to really think about how that looks like, otherwise you're going to miss it, right? The blood comes into the right atrium. It goes through the tricuspid valve into the right ventricle. The right ventricle pumps it into the lung. The lung has 4 blood vessels usually that push it in the left atrium. In the left atrium, through the mitral valve, it goes into the left ventricle, and the left ventricle pumps it into the body, and then you get the oxygen being supplied to all the organs. Now, these valves, the tricuspid valve, the mitral valve, the valve that goes out of the left ventricle is the aortic valve, and the valve that goes out of the right ventricle is the pulmonary valve, goes to the lungs. They can be leaking, they can be thickened, and therefore not opening properly, but they are restricted, and then we call that stenotic. They are tight. Problems with valves are pretty rare today. They were very common before, because if people had tonsillitis and they got rheumatic fever, which you had in less advantaged circumstances, so in Aboriginal communities, in poor communities, in boarding houses where a lot of people were living together, then the valves could be attacked by the Streptococcus bacteria, and they could be thickened, or if they got really bad, they would have holes in them, and we had to replace them. If they were not that bad, then they would over time become very thick and then not flexible, and they got stenotic. With modern medicine and with the antenatal care that we have, rheumatic fever is very rare. However, we are a mining community in WA, and we do see rheumatic fever when we get people that move from mine site to mine site. And in Africa, for instance, and in Asia, rheumatic fever is still rampant. So you do find it, but not in people that have been brought up here. The last one, so the second one, the arteries. Now, arteries, and that is where I have to emphasize that there is a big difference between men and women. You know that already. But women are different from a biological perspective as well. So the arteries in women produce different hormones, different stuff, than the arteries for men. And the heart attack sequence of women is different than in men. And the complaints women present with when they have a heart attack or pending a heart attack is quite different from men. We used to think that it just was because women are tougher, but that's not true. They're not tougher, they're just different. It's a different way of how that works in women, and the treatment should be different. But because of that non-knowledge about the difference in women, heart disease is still today under-recognized in women, and the mortality, the death rate in women is still much higher than in men. Men are wusses. They feel a little bit and say, oh, terrible. Women think it's the kids, so they don't feel very well, and they soldier on. It's quite interesting. And it has nothing to do with menopause, it has nothing to do with anemia, it has nothing to do with everything else that we say we blamed in the past, but it has to do with the fact that the heart produces and works differently in women as compared to men. But like most things in the world, most studies and most treatments are geared to men. Go figure. So I'll come back to the arteries. Now, so the artery is a pipe, simply. But the pipe has a wall, and the wall, I call it the biochemical factory. There is a lot happening in the wall of an artery. And mind you, there is a difference between an artery and a vein. You've got two blood vessels in the body, one with oxygen-rich blood, that's the artery, and that is when it goes from the heart to the organs, those are arteries. When it goes from the organs back to the heart, those are veins. The only difference is that in the lung you've got veins that have a heart, but that is a different story. They don't have this problem. Now the arteries, they will have in the wall what they call foam cells. And the foam cells will degenerate in plaque, what we call plaque. And plaque is a very complicated substance with macrophages, lipid-containing molecules, fibrinogen, bugs. And we know that when I left Rotterdam, we had a technique to put a little bore in the artery to try and clean it out. It was an interesting idea, but a very bad outcome.
Foam cells, do they have an actual purpose before they break down? Like, why are they there?
The foam cells are being made by low-density LDL cholesterol.
Oh, okay.
So if you have that too much, then you get a foam cell, and they seem to trigger an inflammatory reaction that then causes the fibrinogen and the macrophages to come to try and eat it, and that is then the start of the plaque.
I thought they were like in there, but no, they're created.
Yes, not everybody has foam cells. So if you have foam cells at the beginning, so the foam cell is the beginning of the atherosclerosis, right? And we thought that atherosclerosis is just aging, but that's not true. Atherosclerosis is a disease that many of us unfortunately have, but it is not what we expect in a normal blood vessel wall. Now, if you have a little bit of that plaque, that might not be a problem. It becomes a problem in two ways. One is if it grows and grows, right, and it causes a narrowing and not enough blood can go through, depending on what is required. So here you have the heart. The heart pumps, let's say, 80 beats a minute, and then you go and you run up the stairs, and it is 120, 130 beats a minute. That requires a certain amount of oxygen, has to come through here, and then when it's 120, you can't do enough. And then you get that you have a lack of oxygen, so you get acid production, and you get chest discomfort, right? We always have a chest pain, but many people don't have actually pain. They feel a pressing feeling, or a numb feeling, or a funny feeling, and it's not always on their chest. Some people have it in the pulse. Some people have it in the neck. Some people have. I had a patient once who got all his teeth removed. He had pain here. And what the pattern in a particular person depends on what sister cells, because you are made out of two cells, right? And those stem cells, they evolve into the human being as we are now. So the sisters and brothers, so to speak, of the heart cell, if they are in the jaw, you will have the pain in the jaw. And that is actually made us think. If you look at an acacia tree, and the giraffe starts eating one acacia tree, then 100 meters further down the acacia tree, the leaves will close. Huh? Is that a biochemical process that goes through the roots or something? We also have plants that when the larvae starts eating and nibbling one leaf, the other leaves start to produce, I think it was the tobacco plants, start to produce the stuff that they make to try and have the bugs go away. So we don't understand the mechanism why, if you get lack of oxygen in the heart, that signal translates into pain in the jaw, or pain in the chest, or a numb feeling on the chest, pain in the back. However, this is number one. Number two, though, this happens in 40% of the heart attacks. And the majority of the heart attacks And that is my point why prevention is so important. It happens that you have a plaque like that. The plaque wall is not very stable. These arteries, they go up and down. The heart is hanging in the aorta. So the heart pumps, the top part of the heart pumps the blood into the bottom part pumps it into the body. So your heart goes like this. And it is not connected to any other organ. It just hangs on your aorta. The aorta is fixed in your chest, but the heart hangs. So these arteries are connected to the aorta and then to the heart, and they infiltrate the heart. So the top part of the heart, it does this. That part of the artery is being stretched. Then this released, and then that contracts, so then it's stretched here. By the same token, the heart moves three-dimensionally in the air in your chest. So there's a lot of tension on these plaques. And if the plaque ruptures, the content of the plaque comes in contact with the bloodstream, the reaction causes the blood platelets to aggregate, and you get a blood clot that occludes the blood supply, and suddenly that part of the heart that is depending on that blood vessel does not get any oxygen. And that is 60% of the heart attacks have that mechanism. Now, why is that important? If somebody has this without the blood clot, so the day before, and he says, oh, my neighbor had a heart attack, I want to get checked out, and say, all right, run up the stairs and do his stress test, he will have no problem. And they say, you're fine. And the next morning, he has a bloody heart attack because of this mechanism. So if you want to check somebody, you not necessarily want to do a stress test. The first thing you want to know is, do you have plaque? Now, it wouldn't maybe matter if you know that you have plaque if there was nothing that you could do about it. But we can get regression of plaque. We can reduce plaque. We can stabilize plaque. Right? Plus, if you know that you have that, you might want to think about, can I change anything in my lifestyle? Can I be more active? Can I eat differently? Can I then finally stop smoking? Can I give away cocaine? Right? Same one. There you go. And do something to stabilize my atherosclerotic plaque, and therefore get a better outcome. Does it make sense? The other thing you need to know is that if you have plaque here, there is a 30% overlap between stroke risk, kidney failure, and the Germans call it Schaufensterkrankheit, which means that you have narrowings in the blood vessels that go to your legs, so you can walk, and then it starts to hurt, and starts to hurt more, and then you can't walk. So what people do is then they pretend to look at the window of the shop. Huh? That's where the name comes from. So if you find that you have this, if you're smart or have a smart doctor, they will scan your brain and they have a look with a Doppler whether you have any significant problem in your legs. Because knowing means that you can do something about it. Yeah? Now, atherosclerosis in itself takes time. You have only special conditions, people with familial genetic abnormalities of very high fat contents and cholesterol levels and stuff like that, that have these type of problems when they're 20 or early 30. But as soon as you're over 35, if you're getting 40, if you are predisposed to have that, you will find it if you do a CT scan. Now, people say, yeah, do a low intensity CT scan and you'll find calcium. If you have no calcium, you're fine. That's not true. Because the calcification for the plaque happens over time. Right? So yes, if you do an $80 CT scan and you do have calcium, you know you have that process, so then you can have a chat about that with a specialist. If you don't have it, it doesn't necessarily mean that you don't have it. So I always did what they call a CTCA, so CT coronary angiogram. That's the test that shows whether you also have soft plaque. Now, something interesting. I spoke about young ship and things like that. And I spoke about the giraffe and the acacia plant. Recent studies, and I think we're waiting to have confirmation because it was a collaboration between some Chinese and I think Toronto University. So after Wuhan, I don't know who to believe and when, but it makes sense. So they found that the animals in one's gut and the gut itself, the villi of the gut, change over time. They age. And the flora there changes too. We know already that there is a correlation between whatever stuff the gut flora produces with the feel-good center in your brain, and that is part of the obesity problem that we have. Obesity is not just inactivity and eating too much for what we exercise we do, but obesity is more of a problem related to what the gut tells the brain what to do. And the brain dictates how many of the calories you take are being stored away at the fat cell or what is going to be used. Now they suggest that in the aging gut, they found stressors that aggravate this process of atherosclerosis. And in rats, so they checked it in rats and they checked it in humans and they found that, so they had several biomarkers that identified that process. But in rats, they were able to reverse that process when they did a fecal transplant. Sounds gross, huh? But you irrigate your gut with some stuff and kill everything, and then you take some poo of a young person and then you colonize it with some young stuff, and it is a regeneration process. They could show that the villi improved, and they could show that this disappeared. And that is very exciting. It shows that it is complicated, but why is it exciting? It is exciting because, as we know, we have several chemical substances that can reverse some of our problems. I won't say that we can become young again, but you can do a lot about degeneration and degeneration processes. Now we know that this stuff has shown benefit in cancer prevention, in atherosclerotic prevention, and in general death. The only problem we have is that if you just look at the substance, and it is available in red wine, I think 30% more than in white wine, so swap it. But you have to drink like 12 bottles a day or something.
It's better than
And exactly. However, and I think what people always forget is you need to use common sense. There are very nice studies that show despite the advertisements on television by our nice government that all alcohol is very bad for you, studies have shown clearly that if you have one glass of wine with your meal, you live longer, you have less chance of cancer, less chance of having a heart attack. And that is, I think, not bad. Not bad. Now, we go to the last one, and that is the electrical system. Now, the heart needs to pump. And you have a top out of the heart that has to pump the blood into the bottom part of the heart, so that's completely filled, and then the bottom part pumps. That's the most economical. Now, how can we make sure that it happens? Now, we have a pacemaker cell, looks like a banana, in the top part of the roof of the right atrium, and then the electrical impulse will go over the top part of the heart, like the ripples in the water when you drop a stone in. The speed is 2 meters per second. Now, the atrial wall is not that thick, so there are not that many muscle cells to be activated. So it is able to synchronize both the right and the left atrium together to contract. Now, the heart has an insulation layer between the atria and the ventricles, so that this wave, when it comes here, dies off. It can only go to the bottom part through that particular structure here, which is called the AV node. And the AV node under a microscope are a lot of strands like that, and it's like a brake. So the electricity goes from one to the other one. Ones are slower, ones are faster, and that takes up to 200 milliseconds to go down. And then we have a highly specialized electricity system, the bundle of His, and then two bundle branches, the right and the left bundle. And that activation process goes 5 meters per second. And then this whole heart is activated, and then the bottom part pumps. Right? Now, what type of problems do we have here? We can have that this thing doesn't work very well, and then there is no electrical front and nothing would happen. Now, nature doesn't want that. So we have additional pacemaker cells. We have not many pacemaker cells in here that then will start, but we have critical ones in the ventricle. So if somebody has a top part of the heart that doesn't work properly, then the bottom part of the heart will take over, and it will go usually between 30 and 40 beats a minute. So they don't die, but they don't feel very well, because if you have to pump 5 liters a minute around, if you have 1/3 of that, then you can't meet what you need to do. So you're really tired and things like that. The second problem can be here the AV node, and that is the most common problem if people get an infection of the heart, or certain drugs overdoses, or when you're getting an aging conduction system. And that means that not every beat can go through there because it is being blocked and getting lost. And then you get a block. We call it a block. It's not really a block. It is just going too slow. So you can get a heartbeat, a heartbeat, a heartbeat, a heartbeat, a heartbeat, and then it recuperates and you get a faster heartbeat again. So you can get the longer pauses, and people can get dizzy spells. Or people come into hospital because they have a broken hip. And if nobody asks Why would she break the hip? Or why would he break the hip? Right? Then they don't find this, of course. So that means that you get out of hospital and the same thing, and then they break the neck. Yeah? So so that is one of the things that we are always looking for is, do you have a regular heartbeat or do you have longer pauses? Can it be because this is getting aging? The second problem with the electricity system is that it goes very wild, that it goes very fast or very erratic. And you have several ones that occur in the top part of the heart. 7, sinus tachycardia, atrial tachycardia, aviodinal tachycardia, Wolff-Parkinson-White, atrial fibrillation, and atrial flutter. And the important one is the atrial fibrillation. The irregular heartbeat, the irregular heartbeat. 2 types of people have that. Very fit people, marathon runners, they suffer from atrial fibrillation. Cyclists suffer from atrial fibrillation. Very fit people. And elderly. And my old professor said everybody will get atrial fibrillation if they're getting old enough. Currently we don't believe that anymore, but it is a very common, it's the most common arrhythmia in men. 1 in 10 persons over the age of 70 have it, 1 in 3 over the age of 80 have it. Atrial fibrillation is the rhythm that causes, because it's chaotic. So normally the heart pumps like this, the top part. Atrial fibrillation, it goes like this. The blood doesn't have a laminar flow anymore, but all kind of whirlpools. Platelets and blood products hit each other, break off, causing little thrombi, little blood clots. And if the blood clots travel with the bloodstream and ends up in your finger, not a problem, because the finger can deal with that and clean it up. But if you get it through your carotid into your brain, you call it a stroke. And that is the reason why people that have atrial fibrillation are being put on blood thinners. And it used to be the good old rat poison, which was a terrible, terrible drug with a lot of complications, but we had nothing better. So now we have factor 10 antagonists and things like that, which are much, much better, easier to control, and a much better protection against getting a stroke from atrial fibrillation. Now, atrial fibrillation is a malignant disease. What I mean is, yes, we can manage it. We can control the rate. We can reduce the risk of a blood clot. But still, people with atrial fibrillation might not live as long as people without atrial fibrillation because it is intrinsic to the state and the quality of the atrium. Now, in the marathon runners, people say, how is it possible? Because very fit persons. Nice and shiny on the outside, eh? Right? Muscle, stuff, running marathons. Well, you have to do Boston, New York, and otherwise you're not in. No. I have several colleagues that do that. I think they are blindfolded or something. Because what happens if you do that type of endurance sports is the heart gets bigger. If the heart gets bigger, you get fibrosis. You're replacing your muscle cells with fiber tissue. The border between the fiber tissue and the normal tissue, that's where the atrial fibrillation occurs. Atrial fibrillation begets atrial fibrillation, the heart becomes even bigger, and with the irregular heartbeat, it doesn't pump as efficient anymore, because remember, it has to fully contract coherently to push all the blood down. It doesn't do it. It tries to manage it by increase the rate, but that goes only so far. So they get heart failure over time because the heart cannot produce the energy that it needs to do. That's not good, right? So yes, you run a marathon when you're 40 or when you're 50, oh, fantastic. And then there you go, 70 and it's done, right? So beware. Now we talk about Mr. Warren. This is your aorta. This is the left ventricle. So the blood goes from the left ventricle through two valves into the body. And then immediately outside, there are two arteries, the two coronary arteries that give blood to the heart. You got a right one, the right coronary artery, which is smaller, and you got the left coronary artery. And if you have a narrowing right here at the beginning, that's called a widowmaker, right? And what is typical for the widowmaker is that it is something that grows slowly. We have found that in people 25, 30 years, plaque grows slowly. The heart adapts. The blood vessel becomes a little bit wider. So the lumen, so if this whole thing becomes wider, the whole, for the blood to go through, becomes wider. But it's only a matter of time. And then people will have maybe 1 or 2 days before an uncomfortable feeling, or they're tired, not really, and otherwise they're fine. Then you have a little plaque rupture, because this is a high friction point. The aorta, so the heart hangs on those things. Huh? You get a rupture, it closes, and why do you die? Because suddenly this whole part of the heart, so you talk more than 60% of the heart muscle, suddenly get no blood. That causes electrical instability. The heart, the bottom part of the heart, instead of beating like this or irregular, begins to fibrillate like this, which means there's no blood going anywhere. So within the second, you have no more blood in your brain. The brain says lay down to get more blood, so they collapse, right? And then, resuscitation-wise, if you're there, very low chance that anything. If somebody has that here and I'm doing my best, I think I got 0.5% chance. Why? Because even if I try to restore blood flow, the remaining part of the heart is not enough to maintain a pump function that is reasonable. Now, this and the abnormality in the heart muscle that one is born with, called hypertrophic cardiomyopathy, so that here is the heart that thick. Can we take another color? That the heart muscle is that thick, like this. And if it contracts, that this touches that, so that this blood cannot go out. That is the typical problem of young soccer players or footy players that drop dead on the field, 16, 18-year-olds. They have that, almost without a doubt, right? And that is why I advocated that we should not stop looking after our kids when they leave school. You know, what is it? When they're born, they go to primary and stuff like that, and they see a nurse and they get their immunizations and stuff like that. But when they're, 12, 13, 14, 16, we could also let them see the doctor. Huh? We could teach them about sexual transmission diseases. We could do an ultrasound and see whether it has something like that. And we could educate them to make them aware how their body functions, so that we are there if we find something and can help them. And we should do that for ourselves. I think that at your age, as you're here, every 5 to 6 years, we should do a complete check over and say, okay, where are we at? Because we have options. And we have medications that have shown to cause regression. We have medications that can prevent blood clots. We have procedures that can reduce the chance of atrial fibrillation. We have defibrillators that if you get this fibrillation and you would die, that can give you an internal shock. But that's, of course, must after the meal. You don't want to have to need that. And studies in Finland have shown that if we would just do what we know that will work, exercise enough or move enough, get a dog. I got a dog every time, so now I'm walking the dog 3 times a day. I still got fat, but still, I do my best. If we eat properly, right? If we drink in moderation, if we give smoking away, if we don't do stupid things like cocaine that ruins the inner lining of your blood vessels, that's why young people get heart attacks, then we would not be sitting here. We would not have half of the problems that we currently have. But it's like the COVID and the other things. It's never us. It's never us. We are invincible. That's fine. We only do something when it hits the fan. And I would like you to, think about it and maybe change them and say, well. But then I realized what Ferdy says, you have to find the guy or the girl that is with you and thinks that is a good thing to do. For the guys here, get a female GP. Much more empathetic. They don't stand, my GP is Chinese, she stands always on my feet. I don't know why. Comes too close, I guess. But they have more empathy, and sometimes they are more into the whole prevention thing. Any questions?
Yeah, quick question. Could you go through the positives and negatives of statin treatment for cholesterol? It's extremely common out there.
Yep.
But I understand there's a lot of negatives that go with the use of statins over time.
Sure. Now, statins are excellent drugs, and 20% of people have side effects with them. Statins are shortly a problem of the past, because we have now monoclonal antibodies that do not have side effects and are better than statins. But we still are stuck with statins because they're so dirt cheap, right? Example is England. They are still stuck with simvastatin, that's their first one, and the least potent one, while the rest of the world has 4 or 5 different ones which are more potent. Most of the negative publicity about statins, about memory loss and liver disease and stuff like that, are not true. But to take myself as an example, I tried to take 18 milligrams of atorvastatin, and after 2 weeks, I didn't notice anything, but after 2 weeks playing tennis, I got that much pain in my legs, I had to crawl off the field. I said, no, really? Me? So now I take 20 milligrams every other day, because even 20 milligrams every other day will reduce my risk. And it's all about, I don't have a problem now, but I don't want to get a problem. I just retired. I need to spend all my money and leave my kids nothing. Yeah, so I take my 20 milligrams every other day. Now, if I would have a problem, would get a problem, then I will go to the monoclonal antibodies. And that is, currently, it is an injection twice a month. that you give yourself, like an insulin type of thing. Very easy. The patient I had on it were very happy with it, and it works like a dream. So I think it's going to be a non-issue in the near future, but there is no doubt that the statins have changed the face of the earth as far as my job was concerned. See, before statins, I was sitting in the coronary care unit in Holland, waiting for people getting the heart attack, and then I was monitoring them to see how they died. Now we don't do that. In my last 5 years, I've seen maybe one acute heart attack. I've seen a lot of complications on small ongoing ones, and they get a stent and they get a mini heart attack. I see problems, but the classical heart attack stuff, I haven't seen anymore. And that is because statins, not the aspirin, the statins. Now, aspirins are now also surpassed by gout medication. And one of the ideas of Peter Thompson from Charlie's. And that now the treatment for people that have a stent and need to be on super aspirins is going to be to have a cold gout tablet. The cold gout is the same tablet that you get if you have gout. They say take for 5 or 7 days, 2 tablets a day, and then you go on allopurinol to prevent the gout. So it's a very old medication. But as an anti-inflammatory for the blood vessels, seems to be working very good for males. It doesn't do anything for females. They're still on that.
This is on statins. I saw a study on catalysts a few years ago that said that statins are really only effective after you've had a heart attack. Before that, they don't seem to make a great contribution to reduce the heart attack.
Yeah.
Certainly after you've had a heart attack, it is effective.
Yeah, and it is very effective before the heart attack because they reduce the amount of foam cells. So the bulk of your atherosclerosis reduces. And 80 milligrams of atorvastatin and 40 milligrams of rosuvastatin has shown to cause regression. So less of the rubbish in the arteries. And we have shown that by intravascular ultrasound. So we put a catheter in there, we make an ultrasound picture of the certain length, and then we put them on the different statins and different doses. We brought them back after 8 months and then after a year, and you could clearly show that there was less volume of plaque. Also, the plaque calcifies more heavily. So if your plaque, see, calcium is not bad, because if I showed you that 60% of the heart attacks is because the plaque burst, and then you get the blood clot, and that closes up the blood vessel. If you take a statin, it will cause the plaque to calcify. So it's going to be like concrete. So the chance of bursting is much less. And if you do temperature measurements to see how angry the plaque is, how hot the plaque is, with statins, that diminishes, takes it away. So I'm very confident that as a preventative, statins are doing the job. We also have many data in people with diabetes who have a much higher incidence of cardiovascular disease. People with metabolic syndrome have that. People with hypertension. You give them statins, you reduce the incidence of heart attack and death. That's what I know.
I'm curious what your views on stress, intense stress, and heart.
Beautiful.
It's a good thing?
Yeah, good stress is good, huh?
Well,
It is when you cannot cope with stress.
I'm talking about, somebody with like PTSD or something, like trauma, they're not sleeping well and stuff like that. They're just taking that stress on board.
We have a so-called stress heart, huh? We have a stress heart. And it happens in males, but it is predominantly a female problem. And it is caused probably by overshoot of adrenaline, and you get that the heart gets stunned and doesn't pump. And they come in with chest pain. If you do the blood sample, you think they have a heart attack. the electrocardiogram looks horrible, and then you do the angiogram and the arteries are pristine. That's a stress heart. But that is not what you mentioned. Stress is very bad for you, for more than one reason. The relationship with the heart is that stress causes spasm of the arteries, can induce rupture of the plaque, so you increase your chance of a heart attack. But because if you have plaque, you have it everywhere, so it could also be a stroke or something else. Right? But usually it is related to stress that people cannot cope with. And then you get what you say, you get associated things like problem with sleeping, you kind of do problem solving and this and that. So that's important side of people that have stress and cannot manage it. Now, what are good remedies? One of the best remedies is exercise, because it gets rid of the adrenaline overshoot, which is part of the spastic thing. But then it is a multifactorial thing, because people that don't feel well, they do funny things. They go drink too much, or they seek refuge in drugs or in eating or something that is also not healthy. So then it goes like a roller coaster type of thing. Right?
So if they don't self-medicate with those bad things, therefore self-harm as well. Like, I'm just wondering, like, people say they're really stressed, their heartbeat goes up, like, races and stuff.
Yeah.
But that's not necessarily bad for your heart.
No.
It's just like something.
No, but it is a sign. But
But
it is a sign. Huh? So your heart is a very dumb organ, a pump in the darkness of your chest. It doesn't know anything. It doesn't know whether your adrenaline comes in because you see a naked woman in the street, or that your adrenaline goes up because your boss just fired you, or your adrenaline goes up because you injected yourself with some speed. Just sees this stuff floating around and says, and there it goes, taka, 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 taka. But if you see somebody and he says, I can't sleep, and you measure the pulse and the heart rate is 85, you say, no, it's high. So I would check the thyroid, because that can cause that as well. But it is a sign then that people are not coping with whatever they're going through.
Please on vitamin supplements like K2, these sorts of things, and other things you can do to improve your heart health.
Yeah, not K2.
Not K2, but
No, not K2. So it's an interesting question. It's also a very difficult question, because now you're touching up what could you do in a scientific way to prolong or improve your life? And that depends really on the individual. So somebody that is a little bit on the heavier side, like me, for instance, who still likes to drink and do other stuff, maybe I should take metformin, which is a diabetic medication. Why? Because that would reduce my liver damage. I wouldn't get a fatty liver. It would reduce my postprandial spike in my glucose, which would give me metabolic syndrome and more of plaque. So I could do that and to try and manage it. I could take vitamin D, or maybe a combination of vitamin D and vitamin C, but am I deficient on that? So I would measure that probably first. Now, living here in WA, maybe I should take a B supplement, because Queensland University has written a very nice article in New England Journal of Medicine, which is a top journal, where they showed that the incidence of BCCs and squamous cell carcinoma of the skin significantly reduces, I think it was 30% or something like that, when you take that, vitamin B3, I think it was. So there is a whole list of stuff that you can do. But the benefit only goes if you know what the initial risk is, right? So if my risk is, let's say, 2% to die the next 10 years of a heart attack, would it be worthwhile for me to take a tablet that would reduce my risk by, make it 1.8 or 1.5? Maybe not. Maybe if I just go for a run, I'll make sure that I run the dog and drink a glass of that stuff, maybe I'm going to be 1.9 and that's good enough, but I have a happy life. And happiness has also shown to be a great important promoter of health and not having heart attacks and all that kind of stuff, no stress. So that's a difficult one. Just going to the pharmacy and say, okay, I'll have everything, thank you very much, I think it's not a smart idea.
What are your opinion on this calcium score that you're advertising?
Yeah, so that's what I said. So the cheap CT scan is the calcium score. The good thing about the calcium score is that it is cheap, and if you have calcium, you know that you have a problem. If the calcium score shows no calcium, then you don't know whether you have soft plaque, so you still then are up for the $300 for the CT core and angiogram if you want to go down that road.
So an angiogram is the gold standard?
CT core and angiogram is the gold standard. And now with the new software in the CT core and angiograms, they are also much better to predict what the consistency of the plaque is. In other words, what is the actual risk of that particular plaque to rupture and give you a heart attack.
What is average, shall we say, for a calcium score? What's good, bad, or different? Or does it depend on the person?
Calcium score, if you have a calcium score of 0, you have no calcium, great.
Okay.
You still might have soft plaque. If you have a calcium score of 5 or 400, it means you have plaque. Now 400, you have a lot of plaque, but that could be stable.
Thank you very much.
Right? Thank you very much.
That's one at RACI.
Well, thank you very much. The book I wrote, you can get it in the library, and you don't have to pay for it. If you want to have one for yourself, then it's online on Amazon. The title is Your Heart Maintenance for Jansen. I think they sell it for $30. I think half of it goes to poor people in India or something. I get nothing. But it might help you. So the whole thing goes along the same vein, but I go in more detail also about food, exercise, different types of food that people use or do not want to use, and you might find it interesting. But any library has it, I saw. All right? Good. Thank you for having me.
Thank you.